Yes.
Okay, fine. So you've just seen an identifier that we are recording this, so just please bear that in mind, and we will get this started. So what we're going to do this is an exploration. We're going to try and tie together a whole series of ideas that really, I don't know, maybe properly have their homes in different locations, but we're going to try and pull them together and make a coherent package out of this. So you're going to be following a chain of reasoning. And as we do that, we really want this to be interactive. This is an exploration. And so we are hoping that you will chime in, identify the things that you're thinking, and try to capture some of the issues as they crop up in your own practice. So let's do the background piece. So this land acknowledgement is so we're based in London. So this is on the forks of the Antler River. So this is our location and our connection to the physical space that we have. So we acknowledge that we're gathered today on the traditional lands of the Anishinaabeg, the Haudenosaunee, the Lunar Fuak, and Atawandaron. We acknowledge all the treaties that are specific to this area. This land continues to be home to diverse Indigenous people, First Nations, Métis, and Inuit, whom we recognise as contemporary stewards of the land and vital contributors to society. This land acknowledgement is a first step towards, and a tiny step towards, reconciliation. Awareness means nothing without action. It is important that we, all of us, take the necessary steps towards decolonizing our practices. We encourage everyone to be informed about the traditional lands, treaties, histories, and cultures of the Indigenous people local to their region. Let me do the normal disclosure piece. We had, this is who I am. We have no conflicts of interest. We have no financial sponsors. Conflict of interest declaration. We are not making recommendations for any treatments, and so there is no there's no room for bias there. Okay, so let's get into what we're going to be doing this morning. This is an overview. This is a sort of a taking you through the chain of reasoning that we're going to follow. The first piece, and in a whole bunch of cases, we're going to be saying things that we're just maybe putting them together in a slightly different way. So healthcare is a psychologically rich environment. Now we're coming at this because we're interested in the moral richness of that environment. So you could think about sort of the moral features of our lives as a sort of a subset of psychological features. So healthcare is morally rich. And what I'm trying to capture there is the idea that it engages us, healthcare necessarily engages us as moral beings. And when I say a moral being, what I'm after is the idea that we live our lives connecting with the world around us in a way that sometimes people talk about a moral faculty. We evaluate our environment, we evaluate the situations that we're in, we evaluate the people that we work with on moral grounds all of the time. We use the concepts, inevitably use the concepts good and bad, right and wrong, things like fair and unfair. We see the world through that lens, that moral lens, and that's the piece we're going to be picking up today, of course. I think you can think about those moral phenomena, those moral states, as a subset of psychological states. So if you like, you can think about a concept. I've used the example of gratitude here. Gratitude is it's a moral idea, that recognition that we owe we talk about a debt of gratitude. We owe a debt of gratitude because of some features of the world, of the environment around us. So I want to do that as a sort of a moral phenomenon, contrast a whole load of psychological phenomena which don't have that same sort of moral import. So I've just used boredom as an example here, but you can think of loads. There are plenty of psychological states that don't entail a moral piece, but I think all of the moral elements of our lives you can think of in psychological terms too. Now, that moral richness of the healthcare environment, the healthcare workplace, I've put for good or ill here. That is, the rewards of healthcare, the rewards of practice in healthcare are, I would say, in the first instance, moral rewards, rewards that accrue to the person. That is the satisfaction that comes from knowing that you have done something significant that has helped somebody, that you've interacted with another person in such a way that their lives have improved. I've used that idea of gratitude. You'll all be familiar with those examples where somebody has said thank you at the end of an interaction, where they acknowledge the impact that you have had on their lives. So that's the good side. That's that's the reason that many of you, probably all of you, got into healthcare in the first place, as opposed to all of the other things that you might have done. That's the good bit. The not so good bit is that those moral elements, those moral interactions can have a negative impact too. So we're using, again, we're sort of tying it to this language of the psychological features of our workplace, the psychosocial features of our workplace. Subset of those are the moral features of the workplace. We're going to be taking a infection prevention and control type approach that looks at the hazards of the workplace. It's an approach, that IPAC approach it maps onto a workplace health and safety approach. So they're all interconnected. What workplace health and safety tries to do, what IPAC tries to do, is to buffer the person, protect the person from the hazards of the workplace. So we're going to be talking about, in particular, the moral hazards of the healthcare workplace. So that's the connection to psychological safety. What we're going to do in this session is we're going to name some of those. We're going to try and specify, identify what the particular moral hazards might be in any one of your practices, in any of the specific work that you do. We want to try and put some categories onto those. So what I mean by that is we want to try and cluster them. Are there sort of, cluster is right. Are there clusters of practices, hazards that we can think of in the same way and potentially deal with, mitigate in the same way? So some of the categories that we're playing with here, and I hope this will become clearer as we go through. Some of the moral hazards of the workplace are caused by things that are contingent, that don't need to be there. And we'll unpack some of those. So those hazards we want to try and eliminate. But there are a whole load of other moral hazards of the healthcare workplace that are essential components of the role, essential elements, or maybe inevitable features of the workplace environment that you're in. So we want to try and separate those out. What things can be eliminated? Which of the hazards are contingent? We can do something about those. Which of them are embedded, necessary features of the work that you do? In which case, we're going to be looking. We won't be looking to eliminate. We can't. What we'll be looking for are the ways in which those hazards can be controlled. So that's that IPAC, or workplace safety approach. It's a prevention approach. Much of the work that gets done on moral distress sort of comes in over on this side. We take the moral distress for granted as a given. That's the experience of the person who's reporting it. It is what it is, and then we seek to work with that individual or people in that sort of same environment to work with them to build things like resilience. I think that's the equivalent of treating somebody after they've been infected. And what we're trying to do here is to push it back up to a preventive approach. So what hazards can we identify that can be controlled, and what are the controls? And that, again, is the core part of the practical piece of the work that we're going to be doing today. And then we're going to finish up with moral PPE and protection of the person. It's a metaphor. So what does that look like? How do you protect? I'm going to use soul language. And don't make me commit to the idea that there is such a thing. I just want to use the metaphor, and the metaphor I'm trying to get at, or the way I'm trying to get what I'm trying to get at here, is how do we protect the core elements of the person? How do we protect you when you are in that environment, which is hazardous, which is toxic? What barriers can we create that can play that role of moral PPE? So this next piece. So there's a Canadian standard for psychological safety in the workplace. I think Aurelia's going to put into the chat. We've got a resource link. I don't know if you count this as cheating, but I was playing very badly with AI, and I asked Copilot or ChatGPT or somebody to do me a resource list on, I said somebody, didn't I? Something, to do me a resource list on psychological factors in the workplace. So that's the list that is being posted in the chat, or the link that's being posted in the chat. You'll be able to go and have a look at it. I am not going to guarantee the quality of all of the elements in that resource list. At least I won't guarantee the links. I think when you look at them, they're all of them quite credible resources. Okay, so these are the psychological features of a workplace, as laid out by the Standard on Psychological Safety in the Workplace. So organizational culture, and go back to that piece I had earlier around what are the contingent features. If you think about organizational culture, that can be hugely supportive, or at the other end of the scale, I don't know, undermining, can itself be a hazard. So so these are sort of dimensions of the workplace. Psychological and social support, clear leadership and expectations, civility and respect. I was going to flag that and put I don't know, do it in red or something. I think civility and respect is a moral aspect of the workplace. I'm going to try and unpack that a little bit later on. I think the respect idea is the idea that we treat other people with appropriate consideration. So that means that we treat other people as people. I think it probably also means that we respect other people's something like autonomy, independence, and roles. I think we respect appropriate authority. All of that, I think, is embedded in that idea. So I think that's a moral component of the workplace. If I don't treat you with the respect that is due you as a person, then I am, I don't know, I'm poking at you. I'm affronting you, and I'm doing that to you as a moral being, as one moral being to another moral being. You can think about it. So again, but this is the sort of picture of the psychological components of the workplace. Psychological demands, the ability to grow and develop within your roles, recognition and reward. I would put recognition and reward under civility and respect. But anyway, that I'd sort of categorize them a bit differently. Involvement and influence. I think I'd end up putting that under civility and respect. If if an organization respects its employees, then it will deliberately, intentionally seek out their input. Engagement is one that comes down a little further, but their input and engagement into the life of that organization. It is, I would say, disrespectful of the professional roles of a professional workplace if the organizational culture is one straightforwardly of command and control. I think what that does is it undermines the professional capacity of the people who are playing the roles within that organization. So workload management, again, these are the psychological factors, engagement, balance, psychological protection, and protection of physical safety. So those are the 13 elements that have been identified as sort of psychological, psychosocial features of the workplace. The healthcare workplace adds 2 more. And again, this is back to those resource documents. That's the Canadian standard on psychological safety in the workplace. There's a lot of work that's been done by PSHSA, so that is the Public Sector Health and Safety Association. CMHA has done a whole load of work on this topic too. And these 2 features have been added in as psychological dimensions, particularly significant psychological dimensions of the healthcare workplace. So protection from moral distress, which is what we are trying to do today, and support for self-care. Okay. So I've been going at you for 15 minutes or so. What we're doing now is we're going to, there you go. What we're doing now is we're trying to dig deeper into your workplace. So we just gave that list of factors. That's, all of these are elements of a healthcare workplace. Okay, what does that mean in practice? What does that mean to you? What are the, we're calling them here, the job specific psychological factors, or the job demands? And of course, we're doing this in a moral context, the moral hazards of your workplace. So we pose these as a sort of a handful of questions. What would you give as an example of the psychological elements of your workplace? If you were going to do that in a couple of words, what words would you jot down? Maybe even more, going a little deeper, what would you give as an example of a workplace moral hazard? What story would you tell of? So I'd sometimes do this as, what are the stories that you take home with you? What are those incidents or those requirements of your role, elements of your role that engage you as a person, and because we're sort of stuck with the hazard piece, that are the prickly parts of your workplace. So please, I'm looking at the chat, and do you know what I can see in it? Nothing. So what I hope you'll do is jot down some words or phrases there. Maybe you'll tell a little story. Every time I get a group of healthcare workers in a room and ask them about the ethical events, the morally significant events that have cropped up in their practice, everybody's got a story. Everybody's got a story. Everybody's got a story of, I don't know. I'm going to call it a hazard. Maybe let me prompt you. This one has stuck in my mind for years. It was a home care group, actually, many years ago. It would have been a CCAC, and we had a whole load of care coordinators in the room, many of whom were former nurses. That's often how people sort of move into care coordination. And one of the people put her hand up as soon as we stopped, put her hand up at the end. And she said, this happened when I was a nurse. So this is a nursing story. She said that she was in labor and delivery. They had a young woman in who was a member of the Jehovah's Witness community, and the birth did not go well. And mum started, and nurses use a chilling phrase here, she started to bleed out. And they could have saved her. She had her prior commitment that she did not want blood or blood products. They tried to get her husband, on the grounds that at this stage, perhaps she is no longer capable of making her own decisions, and maybe he would say something different. He didn't. He said she's a faithful member of that tradition. And the nurse who was telling me the story said that they watched her die. They watched her orphan her baby, widow her husband, and they could do nothing. That story stuck with that person, that nurse, for her entire life. She went out of that story having been engaged as a person, having been hurt as a person, where, and I don't want to go, where that team had done nothing wrong, where that team had to respect the informed refusal of that patient of a care that would save her life. Those are the sorts of, that's a moral hazard of the workplace. Right, we've got a comment in the chat here about about discharges. So this is pointing to, and we're going to come back and pick this up if we can talk about the roles, the different roles that people have to play within the organization. So hospitals are full. They're all full. There's a pressure from the outside. The ambulances stacked up in the emergency department need to get patients in so that patients could be seen in the emergency department, and then they need to be admitted. And then when their acute care stay is over, they need to be discharged so that there's room for someone else. So what Leanne, I think, is picking up here is, I mean, the way I would sort of come at this is a resource piece, a stewardship principle. How do we maximize the benefit that we can gain from the scarce resource of hospital beds? Well, in order to maximize that benefit, we may well have to encourage, push, nudge people out to places they don't want to go. So something like a patient-centered care principle and something like a community-based stewardship principle, that's a necessary part of that job, but it brings with it a burden, and we're going to unpack some of those. Now, Renee is talking about. I think I'm going to try and capture this, sort of talking about the tragedy, that the burden that comes with working with people who have lived through tragic circumstances. And both of the cases, I think, there's a feeling of powerlessness, helplessness that comes with that. You can see the problem, but you're not able to affect a solution. So we're gonna come back to those. Now, what I want you to do, even if you haven't put anything in the chat, and 30 something of you have not put anything in the chat, will you jot down an example? Just sort of try and capture something that that raises these sorts of thoughts, because I want to come back to it. I'm going to ask you some questions a little later on about the example that you have raised. In particular, what I want to work out or think through is whether the examples that any of you have brought forward are examples of things that can be eliminated, that can be, we could change our structure a bit, we could solve this, or whether they are always going to be parts of the job, parts of the healthcare role. So this is our go at trying to, categorize some healthcare role specific moral hazards. First one, decision making under conditions of great uncertainty where the impacts of the decision are hugely significant. So this happens all of the time in all of your practice. You're making a decision about what to do next, and you'd look the discharge decision that we had just a little further up. That discharge decision is hugely significant, has a huge impact on the lives of the people concerned, and that would be the patient, that would be the whatever location the patient is going to, so potentially the patient's family. It's got a huge impact in that it potentially frees up a bed for somebody else to get the care that they need. But there's profound uncertainty that lies behind that, uncertainty about what the outcome of that decision is going to be. There are good reasons for doing either one of the two things: leave the person in, discharge the person. Good reasons for doing either one of those, but you can't do both. You got to do something. So uncertainty and risk. So I've sort of flagged those. You can think about the categories of patient care decisions that that arise there. Resource allocation decisions are like that too, and they might be patient related, or they might be the types of decisions that are being made by organizational leaders. Another example that we've got here in the chat, let me refer you to it. It's on the one hand, on the other hand. On the one hand, we've got good isolation procedures that are in place for a reason, on the one hand. But if you follow those religiously, then what that means is we're going to have to separate a whole load of people who aren't going to get access. It means they won't get access to the care that they need. They'll be kept in places that are, in effect, harmful to them. So what do? So fine, decision making under conditions of great uncertainty, where the impact of those decisions is hugely significant. So that's sort of one category. I'm not sure if this is actually a subset of the first one. You can think about that, but the idea of saying no. I sometimes say that the most difficult thing for anybody to do in healthcare is to say no, we won't do that. Now, the reason that I'm sort of trying to capture this as a moral hazard is that if you say no to somebody, you're typically saying no to something that they want, maybe something that they need. And you're saying, no, you can't have access to that. We feel that. Most of us hate saying no, just in general hate saying no. So what we're being asked to do in these circumstances is, as part of the role, make a determination that somebody is not eligible for something. And eligible could be all sorts of, you can unpack that in all sorts of different ways. So no, we won't do that. One entire category would be the decision not to offer a resuscitation attempt, and not to offer a resuscitation attempt on the grounds that it is almost certainly not going to benefit the patient, that it's outside the standard of care, in ordinary language, that it's futile, won't work. So not offering a resuscitation attempt under the CPSO, College of Physicians and Surgeons of Ontario guidelines, that is done without requiring the consent of the patient or the substitute decision maker. It's a clinical decision, no, this won't work, so we won't do it. But that's often really difficult to do. Sometimes the no is on resource grounds. No, that service is simply not available. We can't provide that. Sometimes it's on professional practice grounds. So I think that first one, the futility piece, sort of flows into that professional practice. No, I'm sorry, we can't do that. And you can think of the ways in which doing whatever it is might be profoundly beneficial to the patient. But there's a requirement somewhere in there that we say, no, we won't. So I've just sort of flagged this, a moral hazard that compromises our feelings of compassion. It hurts to say no. A third sort of go at this a category, and I think one of the pieces in the chat a little further up captures this idea. It's bearing witness to tragedy. So many of you frequently will be working with people whose lives are disintegrating, whose lives are catastrophically overturned, whose lives are falling apart in one way or another. And you are next to them, bearing witness to that. And often, very often, there is nothing that you can do, nothing that anybody can do. That person's life circumstances and the events that have occurred are just terrible. And whatever we can do to help won't alleviate the terribleness of that situation. So that might be because nothing is possible. It might be because nothing's available. It might be because the patient refuses it. Go back to the story of the nurse in obstetrics. She's helpless because the patient says, no, don't do that. That's the patient's authority, and it binds the healthcare provider here, binds the healthcare provider who could have saved her. That's the tragedy that is felt by that nurse as she told that story all those years afterwards. So moral hazard of the job. I've got another go at this. Disrespect. So remember that psychological factor of the worst workplace was civility and respect. Well, the hazard, the flip side, is disrespect. So I'm doing, are you dissing me? I maybe haven't quite got the accent right. But what I'm trying to capture is the idea that disrespect is a moral affront. It's a workplace hazard. That disrespect might be toward you as a person. So you can think about the ways in which sexism and racism are expressions, profound expressions of profound disrespect. They undercut the person by, intentionally reducing their personhood. So and that can happen in all sorts of different ways. That's the disrespect for the person. You can think about disrespect for your professional role, where I don't know, your knowledge, skill, and experience is dismissed, irrelevant, undermined, as you'll have examples of that. It's an affront. It is an intentional devaluing of, in this case, the person's professional role and authority, expertise and skill. So it's that notion of disrespect that I'm trying to capture, and the reason I'm trying to talk about that as a moral hazard is it doesn't treat you appropriately. It undercuts who you are. It undercuts your role, undermines, maybe a better word than undercuts. And you can think of the ways in which that can occur. That can occur, of course, patience towards you as a professional providing care. It can happen amongst colleagues, and it can happen within an organization. So that sort of disrespect piece, I just sort of put it out there as a role-specific, job-specific moral hazard. Okay. Have we got comments? I feel as if I'm sort of just talking on here. We will do some bit more interactive stuff in a bit. Are you with me still? Can we get a wave out there? Everybody's gone home. Okay, good. Leanne's still there. Leanne, good. I'm waving to you. Okay, we're going to make the sort of the switch to moral distress. We're going to sort of try and good. At least we're getting the odd thumbs up. Somebody's still out there. Okay, so we've done a bit of this before. We're deliberately now trying to make that connection to moral hazard in the workplace. How does that turn into moral distress? So moral distress it's the combination piece. This is the connection part. It's the experience of a moral event. You've got tons of those in the healthcare workplace. That's what we've been trying to identify. This particular definition includes moral tension, moral conflict, moral dilemma, moral uncertainty, or moral constraint. And I'm adding moral affront and moral assault. And then that can cause psychological distress. And that psychological distress can exhibit itself in emotions like anger, frustration, guilt, regret, sadness, powerlessness, and symptoms of stress associated with stress and feeling torn. And there's a connection between the two. It's the moral hazard, the experience of the moral hazard, that becomes the psychological experience of moral distress. And of course, what we're trying to do is to break that chain of transmission. We're trying to get between the moral hazard to prevent the moral distress. So let's see if we can sort of unpack that a bit more. Yeah, we've done this. It's the idea that there's a causal relationship between the event and the experience. So how can we tackle that? How can we get in and do something with that? So I've called this an IPAC informed approach. I came at it because I got this hierarchy of controls thing. And as I started looking at it, I made contact with PSHSA, the Public Sector Health and Safety Association. And the person I was talking to, she put her hands on her hips and pointed at me and said, "Rob," she said, "you do realize that IPAC hierarchy is actually a workplace safety a construction, that it's got its origins in workplace safety." So the IPAC hierarchy of controls, workplace safety hierarchy of controls, most effective: eliminate, get rid of the hazard, substitute, replace the hazard. We're probably not going to talk so much about that. Controls. The IPAC piece uses engineering controls and administrative controls. I'm just going to use the word controls, but we're going to come right back to that. What are the controls that we can insert to protect, separate the person from the hazard? And then finally, what are we going to do with this moral PPE idea? So here we go. This is the process we're working through. Identify and understand the hazard, eliminate or mitigate. This is just sort of grafting that IPAC informed approach onto moral hazards and moral distress. How do we strengthen controls? That's where we're doing the work here. And then you can think about how that gets implemented as we go along. Okay, we're doing this as polls. So this is to wake you up and make sure that you are still there. Aurelia, I think you're going to launch 4 of these, and they're yes, no's. Is decision making under conditions of great uncertainty and high risk an essential element of the healthcare workplace? Question number one. And that's a yes, no answer. Question number two, saying no. Is saying no an essential part of the healthcare workplace? So I want people to answer them. All of them. I'm answering them, you see, so there's going to be at least one answer here. So I'm giving you a minute to do this. And then we'll have a look at what people are saying. Oh, all I can see is my response. Aurelia, can you see the results?
Looks like there are 20 responses here. I'm going to try and share them.
Oh, maybe if I view the bot. No, I'm just getting my response.
If you go into chat, you should be able to see.
Yeah, I just get my responses. That's all. So
if we go into chat, you can see the polls. You can just click view poll.
Yeah, I do that, and I just get mine. Oh, maybe I'm getting all of them. No, maybe
so
I am. Sorry.
Responses.
Oh no, everybody's saying the same thing. Yes, decision making under. Sorry, great uncertainty and risk. Is that part of the job? Yes, all of you are saying yes, it is. Almost everybody says that saying no is part of the job. Everybody says that witnessing tragedy is part of the job. Now, the disrespect one, that's interesting. So 70% are saying yes, it is. 30% are saying no, it isn't. And I suppose maybe what I should identify is that we do have a little bit of ambiguity there that I was trying to capture right at the very beginning. There are the decision making under conditions of great uncertainty and high risk. That is inevitably part of the job. Saying no is, oh no, that was one that somebody said no to. Witnessing tragedy, inevitably part of the job. You can't show up for healthcare and imagine that that's not going to be an element of your workplace. Now, the saying no piece, that's interesting. So most of you said yes, it is a part of the job. I think it is. And I think it is because I think that resources are necessarily limited. So what I'm trying to capture there is the idea that demand will always exceed supply. No matter how much you got, people are going to want more. And if that's the case, there's always going to be a requirement that we say, no, we can't do that. No, that's not available. And if you think about the other grounds for saying no too, there are, if we could do the professional practice piece, the relationship between a patient, and I'm deliberately using the word patient, and let's use a physician here. There's the physician proposes the treatment, offers the treatment, and then the patient gets to, under the consent rules, can accept that treatment or refuse it. But the physician will only offer treatments that are appropriate, will only offer treatments that fall within the standard of care. And if the patient says, I want something that is outside of the standard of care, then the physician should say, no, we won't do that because it's outside of the standard of care. So I think there's plenty to say about this. And in fact, we're going to, this is where our control piece is going to help us, I think. We'll come to that. The disrespect piece, you know, we shouldn't have it. I mean, it should not be a feature of the healthcare workplace. It shouldn't be a feature of any workplace. It shouldn't be a feature in anybody's lives. I mean, we just should treat people decently. It's just, I don't know. I'm not even going to try and, I don't have to defend that. That's just the way people should interact with each other, in a way that is civil, appropriately respectful, just, but of course we don't live in that world. We live in a world where disrespect is, I think, far more prevalent than it should be. So what happens then? We'll come to the controls piece in a minute. Are there ways? Yeah, look, ego, pride, insecurity, and fear. Yep, and there's plenty of all of those to go around. So I'm gonna come back to that. It might be that's where I'm going to talk most about moral PPE. It might be around the disrespect piece, but anyway, we'll get there. Okay, let's move on. Remember, I got you to, or at least I tried to get you to jot down a workplace hazard. Let me ask you. You can put it in the chat or not as you wish. But the example that you gave of a workplace moral hazard, is that part of the job? Is that a feature of that workplace environment, one that we can't eliminate? I really just put it up as a poll. Fine. You can just have a go at that. Jot that down. All right, now let's go back to those psychological hazards. And all we want to do here is just sort of, if you're thinking about those psychological hazards as a part of your workplace, which of them could be fixed, right? So the organizational culture one, that's within people's control. So, if we were doing a next steps piece here, all of the psychological safety work requires organizations sort of as a next step to go off and look at their structures, to look at the way in which they operate, to evaluate the extent to which their, for instance, organizational culture is supportive of psychological health and safety. So again, you can sort of think about these for your own organizations. What standards of psychological and social support are offered? Are leadership and expectations? Is there clear leadership and clear expectations? How is civility and respect promoted? I was going to use the word enforced, so let me just use the word, and you can wonder if it's the right word. For certain, I think we can enforce civility and respect amongst colleagues, and for certain, we can expect civility and respect from an organization. We can expect civility and respect from patients, and I wonder if we can enforce it. So let me just put a question mark by next to enforcing that. Go through these other elements. You can design an organization that nurtures growth and development, that recognizes appropriately, rewards appropriately. You can design an organizational culture that involves people, that does not make unmanageable demands of them, that deliberately engages, that promotes balance for the individual, and that takes seriously this idea of psychological protection, which I think is what we are trying to do here. We're trying to ask, okay, what does that protection look like? And then there's physical safety. So what What we're going to move to next is thinking about identification and elimination of the hazards. So we've just went through that list. We're at the point, we're sort of at point B, we're looking for the ways in which we can control the risks in the workplace that are associated with hazards that can't be eliminated. So we're going to pick up this reasonable job demand piece. So this is, these quotations are just taken straight from psychological health and safety in the workplace. But what the part of it that we're doing, how can we control hazards that are a necessary part of the workplace? So we've scheduled this for an hour and a half. So because we've never managed to finish anything in an hour, and we are digging in fairly deeply, I'm going to give you an example. Yeah, so let's use it. So what I'm giving you an example of is IPAC Canada introducing a control to mitigate moral distress in the activities that might be engaged in by IPAC practitioners. So what they did, IPAC Canada developed an IPAC ethical decision-making framework. So what I'm going to suggest is that the use of that decision-making framework is the introduction of a control in the IPAC workplace. It's a control that creates a process that allows people, as they go through the process, to be assured that they're making the best available decision, that they've thought through that decision from a variety of different perspectives, and that they can be reasonably confident that they've done their job the way they are supposed to do it, and they should be as confident as possible that they've got best available answer, least worst answer. So this is, so the guide, so this is just lifted out of that IPAC ethical decision-making framework. The guide can be particularly helpful where a values conflict or moral tension exists in the grey, or where options exist that could pose a risk of harm to patients, residents, visitors, or staff. So somebody had put in one of the polls earlier, in the chat earlier, we've got isolation standards, but we're going to not follow them, not follow those practices because we've got greater demands or different demands on beds. So that is a situation where options exist that could pose a risk of harm to patients, residents, visitors, or staff. This is an example of the moral hazard of decision-making under uncertainty, where there's a values conflict or there's a tension, and where that risk of harm, the moral hazard, has got the potential to cause moral distress. Can we eliminate that hazard? No. What's the control that gets introduced? We protect the practitioner, the IPAC practitioner, by going through a process. And the process that they're going to use is that IPAC decision-making framework. So they give a number of examples in that document. We've put a link to the document there in that slide. They use a gastro outbreak in a long-term care facility and somebody having a birthday party, is sort of a completely ordinary example of, in this case, an IPAC practitioner having to make a decision under conditions of uncertainty and risk. And the idea is that by using the framework, by using the process, what you can do is ensure that you're acting as a good professional should. You can be confident that you're likely to come up with best available response. And that ought to be protective. That's the key piece. You can't eliminate the requirement to make a decision, but by going through the process, you can introduce confidence that that you've done what the good professional should do. Go on, Dr. Ali, you're gonna say something. What do you think?
Oh, I just love the mask, but it doesn't really help for GI outbreaks. But I like the example. You cannot eliminate this, right? Like, and you have to take into account 100-year-old birthday is going to happen probably just once. It's never going to happen.
Yeah. No, thank you. Yeah. So look, all of you, feel free to chime in. I'm interested to hear what you're thinking. I was on an ethics committee meeting this week, and she's the director of a continuing care unit, and the patient patient lives in the community, has some, what shall we say, mental health challenges, requires antibiotic therapy and wound care, which crucially can be administered in the community. So those services are available. She could have them, but she doesn't want care in the community. This particular patient doesn't want the care providers coming into her home. She is, I put here, not incapable. Nobody has said this person is not capable of making her own healthcare decisions, so then she's capable. Should she be admitted? You okay for the question? Does it make sense to you? Poor Michelle, she said no. She said, no, don't meet the criteria. Sorry. The treatment is available in your community, in your home. It's up to you whether you choose to accept it. But we need to preserve, we need to keep the space for the people who need it. Now, so Michelle, she said it was terrible. You could see the look, because you said the moral hazard is saying no, contrary to her feelings of compassion. We could help this person by making that bed available, but will harm somebody else. But saying no is hard for Michelle. Now, what's the control? So I'm using that language of control. How can we make her feel better? Well, what she did is she impartially used the admission criteria and the process of determination of who should be admitted in a way that was fair, that was consistent, and that had the result in this case of doing something that Michelle would far rather not have done. But that was her job. So what we were doing in that ethics committee meeting was trying to support Michelle by saying, yeah, you did what you had to do. You played your role in a way that was professional, in a way that met the standards and expectations of that role. And that required you to say no, which meant that you were doing something that you didn't want to do, but you're doing it because you're committed to the role and to your process. So, yeah, this is, I'm just making some general points here. I think we do this. I think we do it often. That is, we set up processes, we set up standards of practice, and I want to name them as protective controls. So I want to sort of, this is my preachy bit here. I want to sort of try and encourage people to think about those processes, not as, oh, it's another checklist, or no, it's another more paperwork. No, what those processes do is they support the professional in their role, in their professional practice, and that is protective. So Sort of, if you sort of take a step back, we sort of took for granted at the very beginning that healthcare is a profoundly worthwhile practice. So you're engaged in general, in a practice which is hugely valuable, that is profoundly significant in the lives of our communities, and of course profoundly significant in the lives of the patients that you work with. That's a big deal, and it's important. There are a whole bunch of different things that need to get done in that healthcare system. Sometimes that's direct patient care, where you're working with a particular individual, but sometimes it's way bigger than that, or broader than that. Sometimes there are system questions that need to be set. There are resource allocation things that need to be done. Different healthcare, different professionals working in healthcare have got different roles, which come with different moral hazards. I think that's a long-winded way of saying that. So I've just listed some here. There's the patient-centered piece. There's a public health approach, for goodness sake. Public health. The unit of significance in public health is not the person, it's the community. The unit of significance in patient-centered care is the patient. You can think about sort of system questions, resource allocation type questions. In each case, there are professional standards, there are tools, and there are processes that guide how to act. Following those is the professional acting with integrity. And what I want to suggest is that that's protective. That protects the person. So this is in general how those controls work. You identify your role. What is my job? Many of you know I've been doing a lot of work with home care. The role of the care coordinator is interestingly different from many other frontline healthcare professional roles, because it quite explicitly includes an eligibility assessment role. That's often a part of other people's roles too, but it's really explicit in the care coordinator role. So let's identify that. That's a feature of the job. So what's your scope? I think moral distress can be caused when we imagine that we've got control, that our scope extends beyond its legitimate limits. Go back to our nurse's story of standing at the bedside and watching her patient die. She had, if you like, the power to save that person, but not the authority. So her scope is limited because she does not have the authority to override that patient's independent choice. Nobody does. And that's the bit that, that's recognizing her limitations, recognizing that her hands are indeed tied by the patient, and acknowledging that even though she's witnessing something that is terrible, by following the rules that respect that individual as an individual, our nurse has done nothing wrong. So she can feel, oh gosh, I wish I hadn't have been there, but she shouldn't feel guilty. Does that make sense? What we're trying to do is to, unpack in terms of a reflective professional thinking about our roles, to unpack the way in which that's protective, the way in which that can buffer. I don't know if I've got it coming up, to buffer the person. So this is, you can go back to that, question that we asked, what's your story? What's the moral hazard that is a necessary feature of your workplace? And I think all of you said that the items that you'd picked was a necessary feature. What are the controls? What are the protective controls that exist to buffer you, the person, to protect you, the person, to prevent you from being infected with moral distress because we've exercised the appropriate controls. So you can sort of think about that. You can put the answers in the chat if you want, or you can just sort of mull it over a bit. All right. Oh, this is, oh, wait, no, what we're doing here, I gave you that example of the ethics framework that for IPAC practitioners. So all of you work with organizations that have got ethics tools and processes. So many of you will use a version of Ethics SBAR. You'll be on this call typically because you work, you've got access to ethics consultation services. That process, working through an ethics, either an ethics consult or working through the ethics process as part of your team, is absolutely intended to be a protective control. It's intended to prevent the moral hazards of your workplace, that ethical decision making under conditions of huge uncertainty and massive risk. It's intended to protect you, the individual, from moral distress, from experiencing the negative impact of working with that moral hazard. So what it does is it helps you to define the issue. It helps you to define your role, the scope of your role, the authority of the different players that are participating in that. It helps you to think through the issue from the relevant perspectives. It shares the burden of decision making. So, I've just given you some examples. Some of you will use Ethics SBAR, some use IDEA. The home care one is called SCORE, and there are some others kicking around. All right, moral PPE. I told you I was going to use soul language. I like the alliteration here. What we're trying to do is to protect the soul from the role. All of you came into healthcare because you care. You came into healthcare because you wanted to help. That's a moral engagement of you, the person, in the processes and the practices of healthcare. So you're committed. What I think I'm going to try to do is to ask, okay, we need that. We need the commitment. But how can we create a barrier that protects you, the person, from the sometimes toxic environment in which you have to work? We've spoken about some of the processes. Is there anything else we can do? Is there anything else closer to the person that can help? So we're going to try and sort of unpack that. This is a metaphor, right? What we're trying to do with moral PPE is to create a protective barrier. Maybe it's a space between the person, your role, and the moral hazard that's outside there. So let's see if we can have a go at this. So okay, we're digging in deep. What I want to try to do is to say that we, each of us, acquire our moral commitments, our moral values from a whole variety of different sources. I sort of imagine Rob's bucket of values approach to acquiring moral principles and moral values. So, at my mother's knee, my mum was highly instrumental in putting moral values into Rob's bucket. And then I went to school and I got some different ones, and I got a religious upbringing, and that put some different values in there. And then I started working and I had relationships and got married and I've got kids, and all of those things put values in my bucket. And as I'm reflective as we go through that, I keep some of them in there, I take some of them out. I acquired some as a result of my professional roles. All of you on this call did. that as part of your taking on your professional role, you took on some moral commitments. They all sort of come together. Part of those professional roles impose standards and values. So we take that on, and I'm tying that back to the processes that we follow as professionals. So those professional standards, processes, and tools. How does the good professional play their role? Well, you follow the processes. That's what professional integrity looks like under those conditions. And that is protective. So I want to try and drive home the idea that as I take on my professional role, I take on a set of moral commitments that come with that role. That includes acting with professional integrity, and acting with professional integrity is protective. That's a buffer between the hazard, the role, and the soul, the person. So now this is just trying to sort of unpack some of that in a bit more detail. You can sort of, I don't know, play with these ideas. The key features are that we start with roles in healthcare that are profoundly valuable and worthwhile. The next move is that we've committed to that. We then need to understand exactly what that role entails and identify the moral feelings that we're engaging in here. So I've got here, the reaction of when we've said no, the anguish that is experienced by the person who is the recipient of the no, can make you feel terrible. Engages your compassion. You feel as if you've let them down. You feel as if you're responsible for their pain, and that the compassion that you feel is draining. However, what I want to try and do is insert that professional role as personal protection. That's the job. Sometimes I have to ... But if you've performed your role, if I perform my role with integrity, then that's protective. I haven't let people down, so I shouldn't feel as if I have. I'm not responsible for the pain that they have, and I shouldn't feel as if I am. And I empathize. I'm going to say one thing about empathy, and then I'm going to stop. We said that bearing witness to tragedy was an essential part of the healthcare environment, standing close to people as things careen out of control and as their lives fall apart. That's part of the role. So people will talk about empathy. They'll talk about compassion, empathy, and sympathy. Sympathy sort of looks from the outside. Oh, I'm so sorry that's happening to you. That's something. Empathy is something like the ability to understand and to share another's feelings. But here, and I'm wagging my finger. Here, the crucial part is without bonding with them. So if you think about the way in which you feel for your family, the way in which you feel empathy with those that you love, you're bonded to them. Yeah, that's different from this idea of cognitive empathy. This idea of cognitive empathy is that you genuinely understand, but you recognize that it's not your tragedy. So here the idea is something like compassion, empathic understanding without bonding with the other, and coupled with a desire to help. So it's the without bonding. And people will sometimes talk about this as emotional self-regulation. The idea that you can stand next to that tragedy, you can witness the tragedy of the people that you're working with, and you're going to try to help. And you understand what that feels like, but it's not your tragedy. Because again, it's that personal PPE idea, that emotional self-regulation that allows you to self-protect. So I've got it in the chat here. Oh, look, Leanne. Yes, Leanne says, healthcare providers cannot take responsibility for the choices people make for themselves. Oh, yes. So that is, yeah, maybe that gets called, oh, no, is there such a thing as over-compassion? Yeah, I think there is. That's beyond your scope. And it will destroy you. I'll put that too bluntly, perhaps, but if you feel that you have to carry everything, you will be overburdened. Well, the truth is you don't have to carry everything. Now, Amanda has again picked up sort of the flip side of this, and that's the costs to the person of not respecting somebody's autonomy. So yes, overriding somebody else's independent choices is itself, or witnessing that occurring, is itself a moral hazard of the workplace. All right, I'm sort of winding down here. This is an ethics session. How can ethics help? All of your organizations have got ethics programs, ethics frameworks, processes and tools for supporting you as you navigate your way through ethically challenging situations. I think the moral hazards of the workplace, I might use the word ethical instead of moral, and it wouldn't make any difference to where we went with that. It's the same dimension of a person that's being engaged there. We're trying to sort of put in, so the ethics tools and processes, it's a layer of reflection. And that layer of reflection, we hope, can act as a control, as a barrier that enables you to be assured that you have played your role as a good professional, and that should be protective. I'm going to stop. We went on a bit, didn't we? So over to you. Questions, comments, reflections, next steps. What do you think? What more can we do? And then, I'm sure people are just going to drift out as we are doing this. But please, those are the QR codes for an evaluation or for certificate. Thank you, those of you that stuck around for staying with us. Any comments? I think we got a stunned silence. Well, thank you, those of you that stuck through to the end. And if you've got feedback, please send it to us. Dr. Ali.
I was just going to say, Dr. Butcher, thank you as always. This is amazing and a very unique approach to, I guess, things we encounter on a daily basis, right? So thank you for this.
Thank you. Thank you for sticking around and participating there. Take care, all of you. Bye, and thank you.